We're so excited to be here with you all this morning and part of this great conference. My name is Jennifer Smith Ramey, and I'm a second-year doctoral student at Liberty University in the Department of Counselor Education and Family Studies. And I'm so fortunate to be joined by several of my classmates and professors, and I'd like for them to each take a turn to introduce themselves to you this morning. And we'll start with Andrea.
Good morning, everyone. My name is Andrea Garraway. I am a doctoral candidate at Liberty University. I am also a part of a private practice and many other grassroots projects that gives me just a little bit of lens or scope on the topics. I'm excited to be here. Thank you.
Thank you so much. We'll go to Dr. Mwendwa next.
Thank you. I as well am excited to be with all of you today. I'm Dr. Joy Mwendwa. I'm an associate professor at Liberty University, and I'm honored to be presenting with my colleagues who also happen to be my students this morning. And thank you all for making time to be with us today.
Thank you. Rachel.
And good morning also. I'm Rachel Parrish Martin, and I'm a third-year doctoral student. I'm just beginning the dissertation process, and I am also excited to be here.
Thank you, Rachel. And Kimberly.
Hello, everyone. I'm Kim Spellman. I'm in my third year also of the doctoral program. I work in behavioral health outside of that. And I'm so excited to be presenting for you guys today. Thank you for coming.
Thank you. It's a great team to work alongside. Before we jump into our presentation objectives, we'll want to go over just some housekeeping. We'll hold the questions to the very end. We've carved out about 10 minutes of our presentation at the end for Q&A. However, we do want to make the presentation as interactive as possible. So my colleagues will encourage and facilitate discussion primarily through the chat in our Zoom meeting. So before we jump in though, we do have something very important to ask you all about this morning. So if we were in an in-person training or conference, we would likely have some snacks and treats set out for you to enjoy while we were presenting. But in lieu of an in-person training, we did want to get your feedback, and we were very curious as to what is your favorite conference snack item. So if you want to take just a few minutes and jot that down in the chat, and let's see what folks are here. Oh, I see donuts, coffee, bagels, fruit, coffee and donuts, fruit. You guys are a healthy bunch. I like all the bagels, strawberry, cream cheese. Very good. You guys went on mixed nuts. Good to get that protein in. Fruit and chocolate. Very good. Very good. So I shared this slide with my 13-year-old daughter last night, and she said, "Mom, I'm going for coffee and chocolate." So she was all about that coffee and chocolate blend of her diet. So great. So I'm going to jump in with our conference presentation objectives this morning. And we have 3 objectives that we would like to share with you during our time together. The first is to understand the research base for telemental health and telework. And we were fortunate when one small silver lining of the pandemic and the transition to telehealth and telework was that we did have a roadmap. There was a research base, and we will share some of that research base with you this morning. Our second objective is that we will share 2 modifications made by a community behavioral health agency during the pandemic, as the agency transitioned primarily from a face-to-face delivery to a telehealth format, as guided by the aforementioned literature reference. And then third, lastly, our team will offer some generalized lessons learned for other agencies and organizations that may choose to provide telehealth and telework even after this pandemic hopefully comes to an end. Now, to offer some background and some scaffolding, as you all know, behavioral health care agencies experienced not only significant changes to our operations as a result of the pandemic, but quite rapid changes as well. And these changes were largely driven by federal, state, and local regulations that required mitigation strategies. So as such, many behavioral health agencies that utilized a primary face-to-face service delivery in the office and community settings transitioned to audio and video modes of delivery. And then secondarily, counselors transitioned from office and community-based work to working from home or telework. And this required development of work from home procedures with counselors and staff. A case study that we would like to share and offer to you is in regard to Horizon Behavioral Health. And this is the agency that I've worked for the past 16 years in Central Virginia. And Horizon is a community service board. We are one of 40 community service boards in the Commonwealth of Virginia. And by Code of Virginia, a CSB is the single point of entry for all publicly funded mental health, substance use, and intellectual disability services in our Central Virginia community. And Horizon provides a continuum of care from prevention-based services up through residential inpatient services. Prior to the pandemic, most of our service delivery was done through face-to-face interventions and sessions with clients. We offered office-based services, including counseling, assessments, case management, and medication management with our psychiatric staff. And then we also provided or continue to provide an array of community-based services. And I'll give an example. We have a multi-systemic therapy or MST team that provides service in client homes and community settings. And the MST team works with adolescents and family members that have, the adolescent has conduct and externally related behavioral concerns. And that's necessary to have a community-based service just due to the acuity of the behaviors and the fact that we want to work with our clients in their natural environment. So as we transitioned and as Horizon had to on March 13th, transition from face-to-face to telehealth, we had to ensure that our counselors and our direct care providers had the tools and equipment that they needed to be able to provide ethical and competent delivery of care to clients. My agency focuses very heavily on evidence-based services like MST. And so fidelity to the treatment model was important. So we wanted to be sure that as we transition to providing audio and video delivery, that we could do that and still stay true and adherent to the treatment models that we knew were effective. In order to do that, we recognized that we needed to have training for our counselors. We needed to ensure that they had a level of competence to be able to deliver quality and ethical telehealth services. So early on in March, we identified multi-hour training that they could attend that went over topics on telehealth like informed consent, confidentiality. We wanted to again ensure that they had all the tools and equipment and support that they needed to be able to deliver telehealth services. And fortunately, we have a research base that guided our preparations. And Rachel will share with us some of that research base. So Rachel, I'll turn it over to you.
Thank you, Jennifer. So research in telemental health has advanced rapidly since 2003 and indicates that telemental health is effective for diagnosis and assessment across many adult, child, geriatric, and ethnic populations. Telemental health is also effective for treating many disorders in various settings, including emergency and home health. Equally positive outcomes have been found for collaborative, asynchronous, and mobile models of care. Telemental health appears to be comparable to in-person care. Overall, telemental health is effective and increases access to care. A large body of evidence indicates that patients and caregivers are generally satisfied with telemental health. This complements the widely held view that telemental health can play an important role for supporting remote and rural patients. Patients can avoid the inconvenience of travel for a face-to-face appointment. Given patient and caregiver satisfaction with telemental health, providers can feel confident that this form of service delivery enables health care for patients in remote areas and is not a barrier from the patient or caregiver's perspective. While telemental health does not replace face-to-face appointments, it does offer an alternative mode of service delivery that, when integrated into an established service, could form part of patient choice when clinically safe and appropriate. Aligning mental health care service with patients' expectations and needs can lead to overall patient satisfaction. And with that, I'll ask, so what has been the biggest challenge toward provision of telehealth at your agency or organization? And how have you addressed this challenge? And I would just encourage you to write your answers in the chat. Okay, let's see. So, okay, yeah, so I'm seeing paperwork, getting the paperwork to function, understanding all the state and federal laws. Yeah, I agree. I've run into that in my telemental health practice as well, with the changes with COVID, especially, which I think we'll be talking about as well in this presentation. And working from home with dogs and children interrupting sessions. Yeah, absolutely. And we'll talk about that as well. Some strategies of, how to establish boundaries between work and home life responsibilities. Clients being unfamiliar with the use of technology. Yes, I agree. That is a challenge as well. That's a good point. Clients not showing up for session. Absolutely. Absolutely. It's been a huge challenge for our practice. The limit, I can't quite read that. Is there an interpretation on that one? Limit. Okay. So yeah, thank you for sharing these. I really appreciate that. So I think, Jennifer, we can move on to the next slide. Okay. So addressing job satisfaction and engagement. Because of technological advancements in communication, telemental health allows employees to work from almost anywhere. Teleworking offers many benefits at the organizational and individual levels, such as increased employee performance, decreased organizational expenses, higher employee morale, and more employee autonomy. Personality factors of extroversion, openness, agreeableness, and conscientiousness are positively correlated with job satisfaction. Significant moderating effects for the relationship between openness and phone and video communication and agreeableness and phone communication have been found in the research. The literature also suggests the importance of agency leadership using a variety of communication channels to stay engaged with telemental health professionals. Overall, a positive relationship between teleworking and job satisfaction has been proven in the research. So what are some of the ways your agency leadership has stayed engaged with teleworkers? Please feel free to share that in the chat.
I'm just going to jump in real quick. We were hearing some background noise, so if you could please stay on mute, that might minimize the background noise. Thank you.
Did everyone hear the question?
Do I need to repeat it?
Maybe because of the background noise.
Okay. So what are some of the ways your agency leadership has stayed engaged with teleworkers? So I don't know how well you were able to hear me because I could hear myself okay. I couldn't hear the background noise, but I was just saying that the literature suggests the importance of agency leadership using a variety of channels to stay engaged with workers. So I was just curious if anyone has anything to share on that. Okay, so yeah, weekly virtual supervision meetings. Absolutely. I like that. My job site also has an asynchronous kind of blog where we come together and share questions so we can, share at our convenience. Access, to text your supervision. Yeah, there's various ways to stay in touch, text, email. Okay. So yeah, thank you for sharing those. Okay. Absolutely. Let's move on. So despite the wide acceptance of telemental health, there are negative effects for therapists as well. Research indicates that telework exhaustion can result from isolation from coworkers and managers. Lack of access to information can lead to communication difficulties within mental health organizations, leaving some to feel out of the loop. Research highlights the importance of individual differences with job satisfaction in telemental health. The International Telework Association and Council argue that psychological attributes rather than technological barriers could explain why teleworking is not ideal for everyone. For example, people who like to control their work pace and avoid face-to-face interactions generally gravitate towards telemental health. Personal characteristics such as self-discipline, amount of household distractions, and preference to work with a team will influence job satisfaction. So we can move to the next slide. The literature also suggests that clinical supervisors can reduce social isolation from coworkers by providing regularly scheduled online meetings and daily support through various modes of communication. Additionally, telemental health professionals can improve work satisfaction by establishing and maintaining boundaries between work and home life. Next slide, please. Okay, and I'll just finish up. I was off one slide, I apologize. While there are disadvantages to telemental health, the advantages outweigh the disadvantages when it comes to job satisfaction. Future research can address the question of how to accurately measure both patient and caregiver satisfaction with telemental health and how this can be sustained long term.
Oh, and now we have Kim.
Thank you so much, Jennifer. Sorry, I was muted. Okay, so we're going to take a look at modifications made by community behavioral health agencies. And we have listed here work from home, telemental health, and telesupervision. In response to mitigation strategies and concerns raised by counselors, many agencies have developed work from home procedures, as they talked about earlier, for counselors. As research revealed that teleworkers achieve significant benefits from these arrangements, such as improved work-life balance. Additional benefits include increased social distancing, reducing potential infectious exposure, reducing the strain on healthcare systems by minimizing the surge of client demands on mental health facilities, and reducing the use of personal protective equipment by the mental health providers. Many agencies transition from face-to-face services to telemental health. Initially, new mental health clients, as well as established clients, faced acute reactions with less access to care than they would have normally received. However, many of these individuals are now benefiting from the implementation of telemental health options. The mental health profession has been able to make a smooth transition due to its uniquely poised positioning to benefit from the ubiquity of technologies capable of supporting synchronous communication between therapists and their clients. Agencies have also been able to provide telesupervision to counselors and residents in counseling to ensure that effective and ethical clinical care be provided for the duration of the pandemic and to ensure safety for the supervisor and supervisees. We can go ahead to the next slide. Here, I just want to take a few minutes just to add. I know that you guys answered similar questions, but I just wanted you to type in the chat, what were some modifications made by your agency or organization during the pandemic? And then we'll talk about some of the ones that was made to my agency. So we'll just take a few minutes to do that. Modified forms. Focus lots on social media, implementing simple practice. I don't know if I can see it all. Okay, great. Well, thank you so much for that information. We have similar changes. I'm sure that a lot of the changes that have been made are very similar from practice to practice. Here, I just want to talk about the provider adaptations, what we did to adapt to this emergent change in our situation because of COVID-19. So we reminded both the counselors and the clients of the need for self-care for us to avoid burnout and to maintain mental stability while coping with situations like bereavement, isolation, loss of income, and following the guidelines for physical distancing and sheltering in place. We have suggested exercises for self-care, such as yoga, walking, stretching, just to keep the mind relaxed and the body. We have recommended that individuals reach out to their loved ones by phone, social media, email to stay connected socially during times of physical distancing. And also that they maintain adequate sleep and maintaining good eating habits. We also, at Road to Recovery Behavioral Health Center, reduced some fees, such as discounted out-of-pocket fees and waived cancellation fees for the duration of the pandemic. And this has also benefited the clients and removed that economic burden of care. Just maintain the continuity of care, providing such providers should maintain updated continuity of care plans to include this transition of care to telemental health platforms. We're hopeful that maintaining the continuity of care to the fullest extent possible will help us avoid additional negative consequences from delayed preventive, chronic, and routine care. Advocacy. In an effort to soften the blow of behavioral health disparities, we've responded by providing tailored services that are accessible, culturally responsive, and cost-effective to meet the needs of each individual client. You can go ahead to the next slide. One of the other great things that I personally did was to just reach out to the state representative and senator in support of including that Medicare legislation. It's HR 945. This bill addresses behavioral health disparities and barriers that have been exploited by the pandemic. And they'll provide clients with increased access to care and allow counselors to provide the services in the high need communities and also across the country under Medicare, if passed. Okay, so self-care. So now we're going to move on to feedback from counselors. So we have some pros and cons. The pros, it's increased participation, flexibility, efficiency, reduced no-shows, visibility into client's environment, and the preservation of the relationship between the counselor and client. So see, telemental health may increase participation of medical or socially vulnerable clients, or the ones that do not have immediate access to providers, such as our elderly or people out in rural areas. Overall, staff members like telehealth, and they hope will keep using it as an option in the future. It allows more flexibility for staff and clients to squeeze someone in, like if they have a cancellation, or if someone, if they can see someone earlier or later in the day, providing a more efficient office flow. It cuts down on no-shows due to transportation or childcare issues and allows the therapist to see into that client's environment. The telemental health may also preserve the counselor-client relationship during times when a face-to-face visit is not feasible or practical. The cons. The cons of telemental health, it's technical issues that I heard someone talk about earlier. I think we all been experiencing those. And it's not great for clients who are already isolated and should really be getting out more. It's hard to tell if clients are using substances if they're not coming into the office, like to have their drug screens done. Some clients have difficulty treating some clients have difficulty using telemental health. Oh, like a real appointment. Oh, they feel like they don't have to maintain the privacy or carve out enough time to spend on the platform. Cultural acceptance is another issue. There's not a big problem with this cultural acceptance, but it's something to think about whether your clients culturally accept virtual therapy sessions in lieu of face-to-face visits. This could also be a limitation to telemental health. Okay. And that's all I have. I think we're going to move on to Andrea now.
Thank you. Thank you, Kim.
Oh, you're welcome.
All right. First up for me is lessons that we've learned. And I wanted to start with access. There is a general consensus around telemental health counselors that we should have done this a long time ago for some of the pros that we've heard already from Kim's section, and also perhaps could have normalized or limit some of the cons. Some of the things that we know about our profession, it has been deemed a soft science, partly because we don't integrate, or we have not well integrated technological advances that's been long has been there. So we're kind of behind the 8 ball when it comes to that. Even when clinicians broke away and started to integrate that, we noticed resistance from some of the more seasoned folks. And then we also even noticed a bit of shaming because we didn't want to change with the time. We didn't want to move in a direction that will reduce the, as I've heard it referred to in the past, that touchy-feely connectivity that makes the 4 walls work so well for us. So I generally believe that had we moved in this direction a bit sooner, we could have maybe troubleshoot some of those things that have been a con and be able to reach some of the communities that, quite frankly, was denied care. Giving you an example, in substance abuse specifically, needing treatment facilities for age-specific teens or gender, not having a support group available to them. Some people have to travel maybe a town or 2 over to be able to have access, or maybe stay on a waiting list that may take months, et cetera, to be able to access care. So that was one of the first things that I wanted to address. Another thing we have learned is, how do we adapt? And our hands were forced. Adaptation was forced, and we adapted beautifully, might I add. So new strategies to build, maintain communication, and making sure that rapport is there. New studies came out or maybe resurfaced about looking directly into the camera, making sure that your hands are visible, because that emotes feelings of trust, etc. Even our attending skills have heightened the leaning in, the actual noticing of their eyes looking down and asking them specifically, what are your hands telling me? I can't see it. What does it feel like? So it really enhanced some of the things that we've been well familiar with, but then taking it to another level because we had to rely more on our clients to pull that out versus that intuitive nature that we are accustomed to. Also, we noticed that our assessments have been different, being able to do shorter assessments, whether that is a CCA or perhaps a trauma assessment. We became hypersensitive to not re-trigger a client, especially being far away. and finding tactful ways to still obtain and gather that data, but not do it in a way that we've left our clients raw and vulnerable. Now, I think we did a really good job in office to maybe pad that, but then finding that other niche to still have our clients communicate. So we might see a shorter stint per session, but assessment may be happening overall longer period of time, which quite frankly, most of our ethical boards and provisions recommend that assessment is ongoing. So being able to use that to our advantage is a beautiful thing. We've seen license requirements, which usually would take a very long time. If you are aware of the process, all of the paperwork, all of the time to gather the signature became a lot more efficient online. I did wanted to share a bit more about this. I don't know if it's just my opinion, but it almost seemed like our board deceived us. We were told that, hey, if we sending our package is going to take anywhere from like 6 to 10 weeks to hear back from them. And in some states, they were allowing us to get license or reciprocity, for instance, in a matter of days. For instance, Washington, D.C. or South Carolina, they allowed reciprocity for the first time. And anybody who have moved or relocated understand exactly what I'm talking about there. They also would give you such a hassle to even switch, but then they were inviting you to switch. They were asking you to be dual licensed so that we can handle the masses. So that's one of the things I believe that we learned, that it's an easy way to do it, and some of the hassle, I believe, can be cut down. I don't think we will go back. Another thing we have seen is NA and AA support groups. We were and still worried about anonymity, et cetera, but we've found really great ways to be able to do that. And then our malpractice insurance have definitely ensured that we are now protected, which I so appreciate. If a client is in crisis and this is our way of accessing them, I really needed my insurance as us all to be able to cover us as we continue to deliver virtual services. Now, what about that client that have moved out of state? So, I'm in my home state. However, client needed to consolidate, move back home with their parents. Do I just abruptly cut the work that we've been doing, sever that relationship? So even us being able to maintain that per our board and per our insurance was a very beautiful thing. Now, we've seen even a relaxing on confidentiality in the sense where if a client is in crisis, we can call another state emergency hotline, which was not a thing that we were accustomed to. And that became applicable or accessible to us from HIPAA, which that gave us another thing. So we've learned lots of great lessons here to be able to move our profession forward. And I will genuinely say that this is a train that cannot be stopped. For instance, if we're talking about establishing protocols, laboratory testing, about prescription and scheduling, those two, prescription, for instance, have now became interwoven into our world where there isn't as much doctor shopping. We are communicating better, for instance. So those are just some highlights I wanted to add. And one more before I close, I wanted to add the fact that our board have allowed us to not only keep working with our clients, they have extended deadlines for us where if our license is nearing expiration date, for instance, they extended that grace period. Also, them and even SAMHSA and bigger bodies, even ACA, gave so many free training on telehealth. So protocols have been established so much so that anybody that wanted to work during the pandemic and really access this population, they have said, hey, we really need for you to be there. And they've extended that to us. So I'm grateful that we were able to learn these lessons. And I'm wondering, what are some lessons that I missed? What did you guys figure out? And this can be very top shelf, or it can just be that it works. Therapy works as long as that rapport is there, and all of our clinical skills and models that we've heard about in the research from Rochelle's section. What works for you guys? I'll just allow a minute here and then we'll move on, because I think we'll have another opportunity to come back right at the end. So I'm fine with us moving on. Thank you, guys. Okay. Okay. Thank you, Marie.
Thank you, Andrea. So continuing on this theme of the lessons that we've learned, let's talk a little bit about work-life balance. Andrea just talked about the strain and there's no stopping it. So as we think about that, I want to talk about briefly 4 points that researchers highlighted, and I hopefully some of this will really hit home with us. So it's important to establish a dedicated workspace. Now, all of us, maybe we've seen this on YouTube, or we are the people who are on YouTube. We've had to be very creative thinking about our workspaces. Some of us have had to sit in a closet or in the hallway or in the bathroom, because you had during lockdown in particular, we had to make it work, and we continue to have to make it work. But if possible, try and establish a dedicated workspace. Connected to this, I think it's really important for counselor educators or supervisors who are working with, counselors in training who are working in community agencies to actually have a conversation about workspace. I mean, yes, it's agreed that we are constantly in supervision having a conversation about your work-life balance, but let's brainstorm. We've never been here before. So how does that actually look like? Literally brainstorming that. Let's talk about, backgrounds, or perhaps even pull in IT. Let's have them help us, as within the counselor education world, have IT help do some trainings for us. As we think about how do backgrounds work, or we talked about technological difficulties, having those people really help us in the process. So connected to that first point, the idea of just being able to close the door between work and living space. So I think what's really interesting about our profession, as we know, we have this added element that requires that we ensure confidentiality. So our spaces need to have this element of security, perhaps unlike somebody else. So if the only space I had in my own small home was the dining room, which I'm still going to eat dinner on and other things, what about confidentiality? How does that look like? Hence why people have had to be creative in identifying other spaces. But I think this closing of the door between the work and the living space, as we think of this element of self-care and work-life balance, I think there's the literal closing, and then there's also the metaphorical closing. And particularly for myself, working a lot with master's students who are doing counseling and also doc students, so who are working in community agencies themselves, but for supervision, let's talk about how we can, identify, shelf a specific item and bring it up to supervision, but literally close it and be able to bring it up at an appropriate time. The second point is, if I can shut down the computer at the end of the day, that would be great. I owe that, or it would benefit me to do so. And by all means, trying to keep a consistent work schedule. Lindsay, earlier, I think you had mentioned in the chat, we live with the interruptions that come with working in the same home with children and dogs, etc. That is our new reality. So trying to the best of your ability to maintain a consistent work schedule. I have to say though, and perhaps others might agree, the struggle is real. So it's what, 11:46 here in the East Coast. And by 11, before we started, and some of you might relate, I'd already had a meeting with a bunch of students for another presentation. I'd helped my 4- and 7-year-old to take a bath, make their beds, handle a brother-sister spat, get them dressed, make beds. It's a real situation, right? I try my very best to be consistent, but if possible, to the best of your ability, shut down the computer at the end and keep that consistent work schedule. Connected to that, if I can, it's important not to enter that workspace during non-work time. So when mom's done, in my situation, when mom's done, which grading for us never ends, or we're working supervision notes, etc., because it's still the same space, when it is non-work time, making sure that I'm not entering into that workspace, like my actual mindset. And it's important to have a conversation with your family. So thinking about, again, those interruptions, there's an ongoing conversation. Right before I came into our presentation, again, just my kids all know now that mom's in a meeting. And they're fine with that. I'm really privileged and blessed that I have a very supportive partner who we've had to have actual conversation. What's going to work for you? What's going to work for me? But set expectations. Also, not just talk with your family, but set expectations with your clients and with your colleagues. Have a conversation with your clients. Many times we'll talk about this during intake or over the informed consent, but actually have that conversation. If you're in administration or in managerial roles at an agency, you be proactive. Have a conversation. Ensure that your team, the folks that are working with you and for you, are actually ensuring this, are working towards this work-life balance. Next slide, please. So as we think about some future implications for telemental health and telework, if funding streams are in place to support telemental health, agencies really need to consider establishing permanent telework placements for counselors and staff. We know of, perhaps, and you might be aware of this, of other professions who have done the same. I hope that will continue even in our profession. And if not permanent, perhaps they might consider a modified version of telework for a counselor who may just maybe come in to complete trainings or paperwork, but then in other cases, they're really just attending virtual meetings and, some form of a modification. We heard earlier from Kim, who was sharing, and some of my other colleagues, about the benefits of permanent telemental health work. So fewer overhead costs, office space, etc. What might it look like for us as we think about this in the future to really support this research? Let's really do some more research surrounding what's worked, what's not worked, how can we improve this? Next slide, please. Thank you. So before we jump into this final slide, I want us to talk briefly about something that Andrea just touched on briefly. So as a profession, we weren't perhaps all as 100% jump as perhaps other professions into this element of telemental health, or just acknowledging that technology is what it was. And I'm curious briefly, and maybe we'll discuss this in a little while here. Why didn't we? Like, why is it taking us so long? What is that about? And sitting with that, I was struck the other day, I was listening to a podcast. I was struck by this statistic. So according to the US Bureau of Labor Statistics, there are 2.2 million fewer women in the labor force in October 2020 than there were in 2019. But these numbers are significantly higher for minoritized women. Why didn't we do this before? I'm curious, and maybe we'll have that conversation here in a minute when we open it up, but it's taken us a long time, and yet we know of those benefits. So post-pandemic, perhaps organizations can really consider increased supervision, training opportunities through this platform. We know that it's working. I'm excited to see where this is going to go. And even as we engage in this conversation, we know what the goal is. We know we have our client in mind, but then we also have us in mind as we are growing our profession. So thank you for this time, and I'll turn it back on to Jennifer.
Great, thank you all so much. And it looks like we have, I'm going to stop sharing so we can see each other for our final few minutes to have a discussion. I want to get to some of the chat feedback. Let's see, so I've got some good feedback here in the chat. The MCOs didn't always allow or pay well for those services. So I think that's an excellent point that links back to what Kim presented earlier in terms of advocacy. And as counselor educators, that is an important role in the counselor educator identity as we work in the profession, and also as we train our master students to go into these agencies to be able to advocate. Let's see, Marie says, one impression I've gotten from others about taboos that held back telehealth is that somehow you can't work effectively with typical issues in therapy, as though they're somehow unmanageable, such as depression or anxiety. Others cite basic need for in-person attachment, suggesting we can't connect therapeutically in teleservices. And thank you for sharing that, Marie. That's very insightful. And I think we've seen the similar feedback in our area and agency as well. And Jackie adds, we didn't have to. My clinical director, who's been in practice for over 30 years, was convinced that he was an old dog who couldn't learn new tricks and was completely opposed to telehealth until he had to do it. And Jackie, I think your feedback links nicely to some of Andrea's comments and presentation on folks. And I've been in the field also 30 years, but really being able to say, you know, let's be visionary. Let's try some new things as guided by the research base. So great. Thank you for that feedback, Jackie.
Jennifer, let me just add something, perhaps as we're having a few more people respond. I think some of this call to ourselves is also, as we know, is also going to impact our clients. There's this mirroring that happens, or with even our supervisees. I recently was brainstorming with a counselor who was working with a client who's an international student who's a client, and they were going to miss a funeral of somebody who was across in another continent. And for them just brainstorming, and the family agreed that they would face live, that funeral, so they would be part of that. I mean, some of that, the benefits just keep going. So I was connecting to something that Jackie, you were just saying.
That's a great point. And I know in our rural, just to mirror the counseling relationship in our rural localities, we've seen such an increased ability to access clients that normally had not been able to come in for services. That's a great point. Here's a question for my colleagues. Do you guys foresee telehealth as here to stay permanent, or will we go back to face-to-face services?
I vote that it's going to be here permanently, even if it's in a hybrid capacity. But there is no going back from here. We have been, yeah, Lindsay, both. We have been telehelping for a very, very long time, and the masses is now catching up. And if we are to do anything, I would suggest that we continue to model from other professions that have done it swimmingly. For instance, if psychiatrists and MDs can have telehealth and interconnective systems where cancer treatment can be in North Carolina and consult with a doctor in California and receive excellent care, I think us as clinicians can find a way, as we are, to continue evolving and adapting. I wonder what my other colleagues think.
Andrea, I would echo that, and I would just add to it as well, as I saw a connection between telemental health and education. It took a while for, colleges and universities to implement, online education as well. And we saw a lot of pushback with that, with, validating our degrees, even involving hybrid education and online education. And so I agree with you that telemental health is here to stay, and probably in a hybrid capacity as well.
Yes, I agree with both of you. I'm hopeful that it will stay in a hybrid capacity. It's been very helpful with like the marginalized communities, just people who cannot make it there, people who have had difficulty finding ways to pay. It's just been an enormous help for us. And with the flow of the office, I see just a couple of patients in office, and seeing that client jumping right online to see the next client, it's just very smooth. And I think that it would be helpful to have both. Just like you guys, I agree. I hope that it's here to stay.
Absolutely. Just one last comment too, from a counselor educator perspective, thinking about future research, what might it look like for us to really harness the knowledge that a lot of these digital natives who love technology, but are also counselors, how might that look like for them to be the ones to help develop, Andrea, what you were just talking about? Like, so sometimes we're so about, yes, let me just fulfill this curriculum, but what if we were open in them, adjusting, working on an assignment or an internship where they developed something that would really help us move this forward. So maybe just an area of future research and implementation.
Thank you so much, my colleagues. And I want to thank all of our attendees today. Thank you all so much for your interactive feedback that stimulated this great discussion. Thank you to our conference hosts for having us. We really enjoyed our time with you. And again, I would just like to thank Andrea, Rachel, Kim, and Dr. Mwendwa. I'm so proud to work alongside all of you. So I hope everybody has a great rest of your day, and take care.
Thank you. Bye-bye, guys.
Enjoy the rest of your conference. Bye-bye.
Bye.